Good afternoon, good evening, everybody. I'm going to do just a quick round of introductions of the panel, the group from PrecisionOS. So for those of you that don't know me, my name is Sandra Jarvis-Selinger. I'm a professor at the University of British Columbia, and I'm working as an educational academic consultant with PrecisionOS. Danny?
Thank you, Sandra. Danny Goyle, I think I know many of you on the call, orthopedic surgeon, as well as CEO and one of the founders of PrecisionOS. Thank you for joining us today. Tanya?
Thank you. My name is Tanya Romanuk. I'm the Chief Product Officer at Precision, and I know some of the people on the call today, hoping to get to know more of you.
And John? John may have stepped. Oh, there he is.
Sorry, I'm John Brack, and I'm the Chief Operating Officer over here at PrecisionOS.
Thanks. So this is our second meeting for the IMPACT Consortium. So Danny, if you want to put up the deck for us. What we want to do is we obviously welcome back anybody who was able to make the first meeting synchronously. We also sent out the recording for those of you that couldn't make it and may have viewed the recording, but we will carry on from that first meeting. So if you want to put up the agenda. So the opportunity then is to talk a little bit about what came out of the first meeting, have an opportunity in that highlight, which I will provide, to get any feedback or comments from those that either attended synchronously or watched the recording. And then we'll launch into the rest of the agenda, which is forward-looking. So we're going to talk a little bit about virtual reality as a force multiplier, talk about some of the work that we want to do in understanding your programs, highlight some curriculum innovation projects, and as we like to do at the end of these meetings, really talk about the next steps and opportunities that are here for the consortium group. I'm happy for anybody to jump in and ask questions all the way along. We will have time where we will pause for discussion and feedback and perspective, but feel free to raise your hand or turn on your microphone if you want to jump in at any point for clarification, questions, or comments. So to start with, this is a very high-level slide that overviews what we talked about last time in a synthesized way. And so what I want to do is just explain a little bit about what we have here on the slide with the 5 different areas, and then pause for any questions or comments, or if anybody who, as I said, was at the last meeting or watched the last recording that want to add to this, I'm happy to take those perspectives as well. So the 5 areas where the idea of this work, IMPACT, as the collaborative initiative, looking at how we can transform orthopedic residency education by embedding virtual reality into core surgical training. And the whole idea around this group is to really improve learning outcomes, faculty efficiency, and patient care. We had a very fulsome discussion at the last meeting, and what we've synthesized it down is into these 5 areas. So the first one is the idea of consortium engagement. The success of any group meeting together is really understanding how that engagement happens. And so what we want to look at with under the umbrella of consortium engagement is really starting to use your lived experience, your program's adoption of the virtual reality technology and the PrecisionOS platforms and projects to support and give input into understanding how that feedback then can help us support reflection, help us be able to look at sort of the longitudinal opportunities for the work that we're doing here. And so that really underpins the rest of these, but it's something that we want to keep front and center. And obviously any feedback that you have as we go along on our journey with this consortium engagement would be very helpful for us. What's working, things we could be doing differently, all of that kind of feedback is very helpful. When we talk about the longitudinal design, there was a really great discussion at the last meeting about thinking basically what level of training to the level of learner. So what's right for the different residency years? How can we map the PrecisionOS curriculum and training opportunities to the learner levels as a beginning to think about what happens over residency and fellowship and into practice, and really taking that educationally longitudinal design approach so that it isn't a one and done, but you're actually beginning to embed it at different places and spaces in the appropriate levels for the appropriate level of learner. Which leads us in to that idea of the developmental approach. And so once you think about the longitudinal design and starting to map curriculum against learner level, the idea then is, can we use the data that we're gathering out of the projects and the partnerships to begin to really start to have some universal benchmarks from the real use data, which we then can share back out to the consortium, and as any continuous quality improvement approach, be able to adapt those so that it's a starting place. It doesn't mean that it's everything and all things for every resident's educational needs, but it begins to create that opportunity to think about things as being integrated, longitudinal, and developmental. And then the last two pieces, there was some great discussion about what I've called near peer mentoring. And so this is the idea, the concept of learners who are just ahead of more junior learners being those mentors and educators. The most common example are the resident as teacher opportunities, where senior residents could be teaching junior residents could be teaching medical students. And it's just a very different opportunity in that near peer mentoring space than having an attending be teaching a junior, because a lot of that near peer mentoring in education means that the person who's positioning themselves as the educator is just a little bit ahead of the other, and they really understand that peer learning approach. And so how do we build educational and training support for this idea, if it's something that really resonates around supporting residents in their mentorship and education of other learners? And then the last piece was around mapping the KSB, having a mapping approach for how the PrecisionOS educational activities support the ABOS, KSB, EPA needs of programs. And so then how do we do that in a way that is responsive to the programs, and come to understand through the program lens about what is useful and helpful, and be able to move that along, as that is a new process that has launched. So I'll pause, give Danny a chance to say anything, and then what I'd like is to get any feedback, questions, or comments from the group. Danny, anything else to add to that?
Yeah, thank you, Sandra. I think there's some really important considerations here when we think about education, the challenges of integrating something so transformative into a system that's, typically baked in tradition. So I think all these things sort of hit on the key highlights of how we want to move forward with programs. And so thank you for covering them all. I think you were very comprehensive there.
Thank you. Any questions or comments from the participants? Arian.
Oh, there's a question from Arian.
Sorry, was that my name, Aaron?
Yep.
Oh, perfect. Aaron Schronis from the University of Washington. So I was curious, is there a way within the PrecisionOS to specifically assign modules to differing residents that are participating in it? it's one of those things when you log into the system, you're looking through the lens, so you can't look at an email at the same time to remember what the exact module you're looking for is. So you put it back on, back off, you find it. Is there a way that we can highlight the specific 3 to 5 that we want to focus on in particular?
Yeah, that's a really great point, actually, Aaron. I think that, that type of input is so valuable because one of the things we want to do is help the faculty direct the resident on what skills they should practice. And so let's have an offline conversation about that as a secondary way to think about how we can integrate that in a really frictionless way. One comment I will make is we now have an iPhone app that's available on the App Store through Apple. And then, of course, we're going to have the Android version soon. So that might be a really great avenue to have the faculty recommend a case to the resident the day or a few days before a case starts to get them to do that simulation before they come to the OR. So it's an excellent suggestion. Thank you for that.
Yeah, and I would just say the other part of the mapping the curriculum is then to create an opportunity for, just as you described, that what fits, what is expected, what is part of that learning opportunity, and how does that come in with the PrecisionOS training?
Yeah, we spun up a whole section for the VR training. The residents on the R1 year are now part of a basics course, as we call it, and they're expected to use the PrecisionOS to accomplish a couple of very specific cases. And that's where I was thinking it'd be great if we could highlight those in particular. We don't want to remove the rest, obviously, from the device, because I think it's fun to use other things and try other cases. But just to really hyper focus on those couple of benchmarks that we want to hit.
Yeah. I think that's a great suggestion. Thank you for that feedback. Any other comments or questions before I hand it over to Danny? All right.
Thank you, Sandra. So there's one of the things with the adaptation of medicine to the changing workforce, I think is really of importance here. When I was a medical student, 20 or so years ago, there was no such thing as a nurse practitioner, or at least in Canada, no physician assistants. Pharmacists weren't prescribing medications, and the number of hospitalists were minimal. And so when we think of how we've innovated in medicine to deal with the changing work environment of medicine, I think you can see a lot of different examples here. So from a workforce perspective, we've had to increase the number of people to help deal with the clinical volume, as you can see there. Scheduling and access for those people who do that on the call, having a way to do this digitally, online booking, digital triage has dramatically improved the quality of our life. And in fact, the quality of care we provide for patients. And then there's more examples from a diagnostic and monitoring perspective. We can do point of care ultrasound. So if you were a woman who is pregnant, historically, you would have to go to a different place in the hospital to get an ultrasound. Now the ultrasound travels to where the patient is, as an example. And then decision-making guidelines, we use a lot of different tools to help us make decisions in the clinical setting, which we really didn't have before. It was very much antiquated in that regard. And then I'll skip through communication tools and I'll skip to surgical education. We've been doing the same thing for surgical education for hundreds of years. The innovations that we've seen over the years are things like video. For example, video and digital textbooks. I used to carry a bag of textbooks to work or when I was a medical student, but things like that have changed. And so when we think of actual hands-on training, there hasn't really been much in the way of innovation up until now. So how do we, with the changing landscape of how residents train in less hours, the drive for efficiency in the operating room, we need to do something to extend the operative experience outside the OR, because that is the most valuable commodity that we have for teaching. And so when we think about how we can maximize the utilization of that commodity and that asset, which is the OR time, if the residents don't get an opportunity to use that time for skill assessment as well as skill development, it is frankly a lost opportunity. They can't go back in time, and you can't add more hours to their day. So this slide just talks about how medicine continues to adapt. But the one area we haven't really done an adaptation to is really in the surgical education. That's where this software, we believe, comes into play.
So the other thing that we think about when you think about this idea of partnerships is around understanding your program. So the way that I like to think about partnerships and developing partnerships is, if you think about PrecisionOS, we know us. You think about your programs, your academic programs, you know you. And so one of the things that we want to be able to do is engage in an activity where we can come to know you. So one of the ways that I have done that with others, health professions programs in the past, is this concept of branding. And so when we think about branding, we tend to think about sort of the private sector, like what are the brands of companies and how do you know something about their brand? The same thing happens in the educational space. So I put up this graphic that AI generated for me in terms of there are different ways that we can imagine surgical education programs. And how do you start to unpack that brand? The other part that goes along with that then is not only knowing yourself and the way that your program defines itself, but then where are the priorities and goals within your program? And how does that fit with opportunities to partner with PrecisionOS? And before I turn it over to Danny, the idea then is to try to create some understanding of where you're coming from, where your priorities and goals and drivers are, and then really starting to make those kinds of connections. So I'll give Danny a moment to talk a little bit about archetypes in all of this.
Yeah, this is something that Sandra has really championed for us internally, as well as she talks about this with other programs. And when you really think about, I know some of my colleagues are on the call. I see Gus Mazak on the call and Brent. When you think about the programs we trained in, the programs maybe went to fellowship to, and the programs we practice in, all of them have a characteristic type. If I went to Calgary for residency, for example, which was a little bit lighter on the research, really focused on work-life balance. And then I went to London, Ontario, for example, to do a fellowship, highly academic center, extremely academic, which meant they were doing complex cases. Perhaps the residents didn't get a lot of hands-on experience. And so when we start thinking about what archetype our program is, I think we really have to align how best a transformative technology, a digital technology like VR would integrate into your program. And I'll give an example. So we worked with a program that was extremely academic. They prioritize academic publications over surgical skill. And I say that not that there was intention there that do that they would minimize surgical skill, but the objective of the program was to publish as many papers and go to as many meetings as possible. They actually benefited from the software by publishing research on it. And the residents who graduate, admittedly, with less surgical skill, that was an opportunity for us to talk about how we could use that software for them in adjacent opportunities. But knowing that brand helps us really integrate the solution in a much more meaningful way than without knowing your brand. So that's a part that really resonated with me when Sandra talked about this and introduced this concept of what is your program archetype and how does this software play a role in your residency program?
And so before we move on to talk a little bit about the idea of we know us and how do we start to introduce those different opportunities and concepts, I just want to pause for a moment and get any reactions or questions about this, because I'm sort of foreshadowing the fact that we're not going to be able to unpack what's your brand in this meeting. So it does mean a little bit of work that we would be doing with the different programs after this. So I want to make sure that if there are any questions or comments, we have an opportunity to address those now. Okay. Seeing none, I will then pass it on so we can talk a little bit about the idea of curriculum innovation. And that's really goes back to what I talked about at the beginning with this idea that longitudinal design, integrated and developmental approach, really fitting with who you are, also comes with us being able to highlight and showcase some opportunities for project work. So, Danny?
Yeah, thank you, Sandra. This part is really exciting for us. So we want to bring everybody on this call and the entire consortium that we have, over 80 programs into this curriculum innovation piece. One of the things that we're doing is we're building an immersive reality, virtual reality Hoppenfelds. So we're going to actually start allowing the trainees to do virtual surgical approaches. And to get to that point, we want to take you along for that journey and work with you to say what of this surgical approach learning paradigm is the most important thing, and how do we teach you enough of the virtual approach or a surgical approach that you could go to the operating room and execute on that approach moving forward. So that's the first project, and I'm going to list off 4 of them. And because they're curriculum innovation projects, we can actually work closely together and there's no ethics or IRB requirements needed for this. The second project is when we think of the ultimate simulation experience, and we've been asked this several dozens of times over the years, Danny, I want to bring my patient's X-ray or CT into the virtual operating room so I can practice the exact case I'm about to do in the operating room. We're offering that now. So any program on this call that wants to be involved in this curriculum innovation project, what that involves, and we can talk about the details on a call after this because we're not going to get into the details exactly, but that would involve the program sending PrecisionOS images, either CT or X-ray, and then us turning that around for you and saying your patient's simulation case is now available in the cadaver lab or in the virtual environment. So we're calling that the ultimate simulation experience. There's nothing out there that exists to this point as similar as this. The next is the senior resident as a surgeon educator. We have PGY5s in every single program around the country in the world that are such valuable and knowledge-rich residents. And we want to be able to provide them an opportunity to reinforce the fact that not only are they knowledgeable, but can they teach and actually retain and learn more by training the residents that are more junior to them. So we're calling this project the Go-To Resident. So just to give some details about that project, we would work with a program, work with their PGY5s, and help them teach junior residents using the software, where they actually feel like they're in the operating room and the senior resident is walking the junior through an ankle fracture, through a hip fracture, through different cases on how to do a shoulder arthroscopy. Because if you know how to teach, that means you know the procedure better than it before if you can't teach it or you can't explain it to somebody else. The last one is I'm super sensitive to the fact that the faculty have very little time. And so if I was to create an option where a faculty could go into the software and do one experience that would help them for the rest of the year, we're calling this project the Force Multiplier. So we want to work with faculty directly here to help multiply their surgical experience for all the residents in their program. So without getting into too much detail of this, but if you're interested in teaching more efficiently and actually perhaps even driving efficiency in your operating room, this is the curriculum innovation project that we would love to work with you on. I'll pause there for any questions and any comments from our team on that.
So the one thing I'll say, as people are considering, if they want to comment, is I've done a lot of work in the idea of residents as teachers. And one of the constant feedback and perspectives that we get from residents is there's the expectation to do this, but not the support. And so how can we support them to really be excellent educators, and going back to that near peer mentor concept. And as Danny said, if you learn it and you have to teach it, you certainly know it for yourself. So I think that it does support the idea of the resident as teacher, the opportunity for them to get comfortable in that space, and it also benefits their own clinical knowledge and competence.
Tanya, you had a question, Tanya?
Just a point that I wanted to make, because I think looking at these projects, they could be really really simple, or they could be really meaty. So I just wanted to add a little bit of context around all of them. We think we can get to some really valuable results and learnings within a few short months. They're not projects that we expect to span 6 to 12 months.
Thank you. Any questions on that before I go to the next slide?
So maybe Danny, if you want to just go back for one second
sure.
before I transition. So I guess my question out to the group is, do these resonate? And if so, how, when you think about your program?
Aaron's got a question here.
Oh, I'm just amped for the patient cases in VR. Like, we see so many unique cases that come through Harborview that I think it would just be amazing to have that.
Fantastic. Thank you.
Thanks. Others? It's not a one opportunity to think about this and sort of chew on it and think about what you might be, as Aaron says, amped for. So maybe that helps us go into this next slide, Danny, which is we really want to make the commitment that it isn't just coming out to this call and then kind of being done with it without that support in place. So some of the next steps that we're contemplating, and we'd certainly like to hear from you about other next steps that we need to be aware of, is that we want to be able to reach out to you to come to understand your program, as Danny and I spoke about that idea of branding, some of your priorities, where some of your challenges are that we may be able to align with, how that understanding of some of the common orthopedic program archetypes may help support making some decisions about these kinds of connections. And then, as Danny outlined very briefly, there's some curriculum innovation projects that we feel will really resonate, and how do we start to match those things? So that it's not about just trying to do everything all at once, but really taking a measured approach to this and seeing where you have some opportunity to integrate and make real systems changes. Because one of the things that I will say is that a lot of times, if you're just simply relying on a couple of champions, that's really challenging to do, and that's challenging to support over time, right? Champions, I always say, cheerleaders get weary. And so what you really want to start to see is a systems change where you can start to create this embeddedness, that it becomes second nature, that this is just the way that the curriculum starts to innovate. This is the way the curriculum starts to move. It is more embedded, it's more integrated, and then it doesn't rely on a few people to just keep floating these opportunities up. And so that's the whole goal, is through this connection with the Impact Consortium, coming to understand your program, your priorities, some of your opportunities and needs, and really coming to understand what PrecisionOS can offer in terms of those curriculum innovation projects, I think creates that partnership opportunity in a way that takes a little bit of effort up front, but has a broader payoff in the long term. Tanya?
Thank you. Yeah, and I wanted just to make sure that everyone on the call felt they had full access to myself. And so this is my email address. If you have any questions about any of these projects, what they might entail, what kind of level of lift your institution would be required to participate in, I'm here for you. What we would really love to see is faculty sponsor, a champion, and a number of residents participating in these. We want lots of different views and feedback, and we hope that we can get them off the ground quite quickly and actually have some movement and some results for our next session early next year sometime. So at any time, feel free to reach out to me. I will be your point of contact for these. And I'm looking forward to getting to know your programs more intimately so we can get the right program, the right project started in your institution.
Danny?
Yeah, I agree with everything that's been said. I'd love to hear from some of my colleagues on the call. I know Dr. Mazaka has been a big champion of VR. I'm not sure if he's able to talk. Brent Bamberger's on the call, Dr. Miller. How does all this resonate with you all when we think of brand of your program and the archetype, and how that may help to drive integration into your centers? Oh, the mic's open for you all if you're willing to comment on it. You see Brent's unmuted. Can't hear him for some reason.
Danny, can you hear me?
I can hear you now. Thanks, Dr. Mazaka. Yeah, I sure can.
I don't want to leave you hanging, buddy.
Thank you.
Yeah, I think kind of what you were saying about, I think, the virtual surgical approaches, and then looking at how many times the residents or the trainees go through that, and all the different metrics. I think that's a terrific idea. That'll really give somebody. One of the problems we have right now is the mentorship model, which I think is probably the best, has to go away almost in our system, because we have them rotating with a lot of different people at a lot of different places. So the continuity kind of goes away. Mm-hmm. So I think that would be, really excellent. And then, your idea of educate with less effort, that's a big problem too. I know that, we've been struggling in our system where they always like to say, 3 prongs are, clinical care, education, research, mm-hmm. and innovation. But, education is really not up there with clinical care.
Right.
So, education falls to, just kind of expected to do it. So trying to have people feel engaged and valued based on their education, I think, is a really important thing now more than ever.
It's great points, Gus. And I think, given what you just described, I think that I'll reach out to you separately, or Tanya, myself will, to talk about that force multiplier for you specifically. Because at the end of the day, when I think of what residents have to learn, they have to learn the principles of the procedure. They have to learn the products of the procedure, which implant they're going to use. But they also have to learn the preference of that procedure, meaning the surgeon they're operating with. And so if you do a rotator cuff repair in a very unique way or an ACL, the residents really want to learn that technique about how you do it. So we're working on a way to make that a force multiplier. So when they come to your OR, they already know the Dr. Mazaka way on fixing an ACL reconstruct or doing an ACL, doing a rotator cuff. So I'll reach out to you separately on that force multiplier project. Thank you very much for your comments. Any other comments from the group? We've got a pretty small, intimate group here, so.
Can you hear me?
Hey, Dr. Miller. Yes, we sure can.
This is Dr. Miller in Rochester. So I can identify with everything that's being said, having worked with the residents for about 5 years, but the consistent problem for us, as Danny and I have talked about, is the residents get engaged when they're exposed to the tool, to the applications, but over time, it's hard to keep them engaged because they got so many other demands from their time. And having the more senior people teach the junior people sounds really great, but the senior people are busy with other things. And I just not sure how realistic that is. Having said that, I would just mention that I've seen some of Danny's recent work with see one, do one, sort of teach one type of approach, and his little video clips that are on YouTube. And I think that's really a great idea if you're trying to get the junior residents to jump in and do some of these VR procedures. Having someone show them how to do it would be really instructive, and I think it would allow them to feel more confident about what they're trying to do. So I've thought that if you had a senior person, someone who's an expert on shoulder arthroplasty or whatever, had a video clip of that person, then the residents could listen to that clip or somehow be engaged with that with the technique, and then they could try it out themselves. I think that's a really good approach, but I'm not sure how realistic it is because finding the experts to devote the time to do such a thing is going to be, again, challenging time-wise.
Yeah, it's an excellent point, Dr. Miller. We've actually been quite successful so far in actually getting a surgeon into headset and creating a case. And really, when you think of where the current state is, what residents do today, just because the technology and the access to simulation is they watch a procedure and then they go and perform that procedure in the operating room. And that's unlike any industry that we know, whether it be an instrument or sports. If we imagine LeBron James or Michael Jordan watching a video in the change room before they came out and played a game, and not throwing free throws beforehand. That's sort of the analogy, which I think is quite striking. And what we're able to do now is we've introduced watch, practice, and then perform, because the practice is still available and it's accessible. They can do it whenever they want. So your point is spot on how we're sort of transitioning from watch to perform, to do watch on the iPhone app. And then you can do that exact same procedure in the virtual reality environment and then go ahead and perform it. So thank you for your comments. Very valuable as always.
Yeah, I think it's a great perspective, Dr. Miller. I think one of the things that I will say is that it doesn't matter who it is. If it feels like an add-on, nobody will take the time to do it because they will find like there's always other things to do. The hope is that the idea of residents as teachers and the go-to is that it becomes an embedded activity. And so the idea, we've done a number of analysis at our home institution here at UBC that the reality is the residents are teaching. They're doing it. They do it all the time. The perspective is that they're not being recognized for it and they're not being supported with it. And so that's the other piece of this, is that if we can embed it in their own trajectory of training and they get the benefit of being able to interact and talk aloud and, as Danny said, practice and not just have to imagine it. So I think of the imagery of high level ski racers used to imagine what it was like to go down the hill. And now they can simulate what it's actually like to go down the hill. Right. And so what you've done is you've started to bring in the reality of being able to practice in low stakes environment in a repeated way and embed it rather than add it on.
Any other comments?
I would just add that, part of what we're saying, I think in order for the program to be successful, for the residents to be engaged and to carry on going forward, there has to be an expectation, and that expectation has to come from the faculty level. And the faculty level may be hard for them to develop that expectation unless they're quite familiar with the tool, and most of them aren't. So that's one of the hurdles, I think, is to get the faculty to fully support and have an expectation the residents are going to, in fact, practice ahead of time or devote so much time per month on trying to acquire these skills through VR.
Absolutely.
Thank you, Dr. Miller.
Great point. Right. So if there are no other comments, one of the things that, as I said, we've committed to is to reach out to you to start the conversation about coming to understand what kinds of priorities and goals you have, understanding your program, and then, as Tanya said, being able to set up a call in the new year with maybe, I think we're moving into a little bit more of an application and curriculum innovation and project connections and starting to move that forward. And so what we really see is for the Impact Consortium is it's that idea of the collective being able to be educated by what's happening with the discrete partnerships. So thinking that the partnerships between PrecisionOS and the programs really help us start to create some best practices, be able to use that feedback loop and really understanding perspective to continue to look at how we can move forward with this. Obviously, the idea of how things are working, advice for other programs that may be taking on some of these projects is always helpful as well. And so that's really our commitment, is to really begin to start creating some momentum on this front. Danny or Tanya, any other things to leave the group with?
Tanya?
I think you said it well, Sandra. We're quite excited about these and really looking forward to connecting with you on the call.
Yeah, thank you, Sandra, for your time, and Tanya and John from our team and everybody that's attended. This group continues to get bigger and bigger, and the questions get better and better every time. So we're super excited about creating this community. And as Sandra mentioned, we're setting the standard for the future. So we look forward to the next meeting, and we'll follow up with a recording on this one as well. Thanks, everybody. Have a great night.
Thank you.
Thank you.
Thank you.